Now it's my pleasure to introduce my dear friend and colleague, Dr. Taleb Almansoori. He is Assistant Professor of Radiology, College of Medicine and Health Sciences, United Arab Emirates University. Dr. Taleb will talk about the extended window in thrombectomy. Please, Dr. Taleb.
Okay, so good evening, everybody. Today my name is Taleb Almansoori. I'm working as an assistant professor at the College of Medicine, UAE University. Today I'm gonna speak about the extended window for thrombectomy. First of all, I don't have any disclosures. So the objectives of this talk, first of all, I'll be talking about the major trials for acute stroke that has been happening in the last decade. Then I'll talk about the new AHA guidelines that has been changed accordingly based on these trials. After that, I'll be talking about the endovascular instruments and techniques used in acute stroke intervention, as well as the current challenges in stroke intervention. So in the last decade, there have been so many clinical trials that have changed the management of stroke intervention, namely Mr. Clean, Extended IA, Swift Prime, Escape Trial, and Rebascat. These trials have been recruiting patients from 2010 until 2014, and most of these publications have been out in 2015, and it changed the treatment of stroke intervention. The primary outcomes for these trials, they've been measuring the modified Rankin scales of all patients at 90 days. And the treatment arm for these trials have been using the retrievable stents. So in the thrombectomy arm of these trials showed significant improvement, or better outcomes with the thrombectomy compared to medical management, as we can see with the percentage of the modified Rankin scale for these trials. Those patients showed with substantial TK2B or 3 reperfusion had better 90 days outcomes. In addition, those patients with rapid reperfusion compared to those who didn't have rapid reperfusion had better outcomes by 90 days. 3 years later, there were two major studies, namely the DAWN trial and the DIFFUSE trial. Both studies required the confirmation of the presence of penumbra in their algorithm to proceed with endovascular treatment. However, they were actually looking at those patients who presented late, more than 6 hours, up to 16 and 24 hours. The DAWN trial checked on patients who presented up to 24 hours, where the DIFFUSE 3 up to 16 hours. Now, EVT was initiated based on how much salvageable tissue remains. But in these studies, they were using a special software called RAPID. Now, in the DAWN study, it applies advanced perfusion images to selected patients who could benefit from thrombectomy in the late 6 to 24 hours window. Now, based on their imaging selection, they divided the patients. If they are using RAPID, they divide their patients who are 80 years old and beyond, or less than 80 years old. Now, those with more than or equal to 80 years old should have an NIHSS of more than or equal to 10, with a core less than 21 cc. And those patients with less than 80 years old will have an NIHSS of more than or equal to 10, and with a core less than 31 cc, or with the NIHSS equal or more than 20, with a core less than 51. Now, also they used, they looked at a non-contrast CT scan with DWI with less than 1/3 MCA territory that being affected. In the case of CTA and MRA, there is with the ICA with tandem occlusion or MCA with M1 occlusion. Now, there has been significant benefit in primary outcome. They were using the modified ranking score, and their target was 0 to 2 at 90 days. Now, looking at their data, the proportion of mild disability in the thrombectomy arm was 45%, which ended up being 48 patients out of 107 patients who had the thrombectomy, with a proportion of mild disability in the control arm, which was less than that by 13%. Actually, 13 patients out of 99. Now, 3.5 times, there was a 3.5 times reduction in the risk of mild disability in the thrombectomy arm compared to the control arm. In the diffuse 3, it applies advanced perfusion imaging to select patients who could benefit from thrombectomy in the late 6 to 16 hour window for anterior circulation. Now, that will be based on imaging selection with an ischemic core of less than 70 milliliters, with a ratio of volume of ischemic tissue to initial infarction volume of 1.8 or more, with an absolute volume of potentially reversible ischemia, the number of 15 milliliters or more. Again, among the patients with acute ischemic stroke due to large vessel occlusion who had favorable findings on perfusion imaging, endovascular therapy between 6 to 16 hours after stroke onset plus standard medical therapy resulted in less disability and higher rate of functional independence at 3 months. Now, there was an absolute difference of 28% points in the rate of functional independence at 90 days in favor of endovascular therapy. So basically, these were the results of the diffuse 3. Now, those two big trials changed our belief that from brain is time is brain to image is brain. And the goal of these trials of late presenting acute ischemic stroke trials was to determine whether thrombolytic or endovascular therapy benefit patients who fall outside the 6-hour window for up to 24 hours, which was really a game changer. This is an example of the rapid software used in the DAWN trial. In this case, we have an image showing CBF, cerebral blood flow, of less than 30%. It was quantified to be 44 milliliters with the time max of more than 6 seconds with a volume of 177 milliliters with a mismatch volume of 133 milliliters. So this patient was candidate for endovascular thrombectomy. This is to summarize, this is an algorithm to summarize the studies that has been done in the last decades on how to select patients for endovascular intervention. In 2018, the AHA guidelines have been changed and modified according to these to the findings of the results of these trials. So 18 recommendations regarding mechanical thrombectomy in the 2018 guidelines for management of acute ischemic stroke have been included. 6 have been revised, 5 have been rewarded, 4 new guidelines have been implemented, and 3 were unchanged. Now, this slide is showing the 4 new guidelines that has been implemented based on the findings of the DAWN and diffuse 3 studies, recommending that some patients who are eligible for mechanical thrombectomy should go for mechanical thrombectomy. In addition, blood pressure has to be maintained to get the favorable results. Now, a review of the current techniques. I mean, different techniques have been implemented or have been in the practice of the neurointervention for stroke intervention. So basically, there are three main techniques: the use of third-generation stent retrievals, direct aspiration, or combining the two techniques, which has been mentioned earlier, the stent retrieval as well as the direct aspiration. This technique is called Celumbra because in the earlier days, it was the solitaire stent as well as the penumbra suction system were used together and was called Celumbra. However, there has been a variation among current techniques, which include the use of sedation, whether you have to go for general anesthesia or conscious sedation, device selection. Well, it will be variable from one center to another, depending on the your procurement policy, as well as the preference of the interventionist. In addition, the decision to use balloon guiding catheter or not. Personally, I use a balloon guiding catheter because that's the way I trained. In addition, the technical aspect in stent deployment and retrieval, it varies from one interventionist to another. This slide is showing you the evolution of endovascular devices that has been used in the last, say, 2 decades, starting from 1999 until 2014. There has been a huge revolution in the design as well as the manufacturing of these devices. I mean, the earlier studies regarding thrombectomy showed the failure of thrombectomy over TPA administration that have been attributed to the poor design and of these thrombectomy devices. However, with the third generation devices, I mean, thrombectomy is considered an important treatment for ischemic stroke intervention. Now, this is a schematic representation showing you a balloon guiding catheter that is being deployed in the distal internal carotid artery with a microcatheter in place, reaching the middle cerebral artery, and the stent is being deployed across the clot. This is a magnified view that is showing you the stent being incorporated within the clot, and after that, the clot will be retrieved into the, by the stent through the guiding catheter after taking out the microcatheter. The second technique is the direct aspiration, where there will be the guiding catheter with the aspiration catheter in place just against the bottom of the clot, and from there it will be aspirated through the guiding catheter. This is the third technique, which is the Celumbra. This will be the guiding catheter. The second catheter will be the aspiration catheter. At the end, there will be the stent across the clot. And so it's a double whammy technique where the clot will be incorporated in the within the stent, and in the meantime, there's the suction power through the aspiration catheter. There have been lots of catheters in the market designed by the major companies such as Penumbra, Stryker, Microvention, and Medtronic. So each one of them has its own advantages and disadvantages, depending on the preference of the interventionist. Now, whether to use a stent retriever with balloon guiding catheter or not, there has been a meta-analysis with 2,022 patients, which 1,083 patients have been, a balloon guiding catheter have been used, with 1939 patients who didn't get balloon guiding catheter for their procedure. So this meta-analysis reported that there has been better technical and better clinical outcomes with balloon guiding catheter as compared with the non-balloon guiding catheter group. Patients treated with balloon guiding catheters had higher odds of first pass recanalization with the ticket 3 and the MRS of 0 to 2 compared to the non-balloon guiding catheter group. Balloon guiding catheter group treated patients also had lower odds of mortality as compared to the ones with the non-balloon guiding catheter patients. A survey was done by survey was done for 80 members of the Society of Neurointerventional Surgery regarding endovascular techniques. They reported the following. So they've been asked which technique they prefer. Now, 41.1% of interventionists responded that they prefer direct aspiration without balloon guiding catheter. 32.4% of them responded that they would use lumbar technique without the balloon guiding catheter. Only almost 12% of them responded to use lumbar with balloon guiding catheter. Now, the selection of the technique will be based on the location, the extent of the vascular occlusion, suspected clot characteristics. I mean, if the clot, if you suspect that the clot is soft, I mean, personally, I would go either with direct aspiration or with a stent retriever directly. However, if I feel that the clot is long and is hard and it involves a long segment, I would go with the lumbar with the balloon guiding catheter. I mean, this is my personal belief, but as I said, I mean, it depends on your experience and the way you train. What about the current challenges regarding extending the window for stroke intervention? I mean, the use of NIHSS score for intervention and select your patient, routing a patient to a stroke center, and treatment of large core strokes. Now, initial neurological status is the single most important predictor for stroke outcomes. Now, NIHSS score is used to quickly identify patients with large vessel occlusions who are potentially treatment candidates. Now, there has been a debate in the treatment of patients with the low NIHSS score and M1 occlusion. And Suraj and his group performed a retrospective analysis of a stroke patient who had a low NIHSS score of less than 6, who received endovascular treatment. And they found that the treatment with endovascular intervention is ineffective compared to those who've been managed medically. Okay. Now, trials like DAWN and DIFFUSE have shown good outcomes in patients with moderate NIHSS score, meaning that the cases that they treated were above 6. Now, one rationale for selecting patients with severe neurological deficits is the higher likelihood of the success for using endovascular therapy to remove a large clot. So whenever you have a large clot, that will end up with a higher NIHSS score. That's why we tend to go for those patients to remove the large clot, so patient will end up with better outcomes as compared to low NIHSS score with the small clot. However, in some cases where the outcome for most interventions, they feel it's devastating, like aphasia, for which the affected artery will be a distal M2. Okay. In these cases, some interventionists would go and take out that clot. And I personally believe in that. Whenever I have a patient with aphasia with no other neurological deficit, I think I have to give the patient a chance to to retrieve that clot, because aphasia, I believe, is really a devastating outcome, which no one would like to suffer or have. The second challenge is routing patients to a stroke center. Now, given that that stroke is a time-sensitive disease, it is important for patients to be directed to an appropriate facility to get the care they need. It has been shown that patients with acute ischemic stroke who are transferred to a high-volume stroke center to receive endovascular therapy had reduced mortality rate. However, with the DAWN and DIFFUSE studies, they showed that patients living hours away from primary stroke center should still be transferred. And there's no problem to break down the routing into two-step system based on imaging. So the first set of imaging can be done at a non-stroke center to determine whether transport is necessary. And the second set of imaging can be done at the primary stroke center, where core imaging with the DWI or CTP or CT perfusion can be performed. So these are the recommendations. I mean, we have to implement after getting the results of DAWN and DIFFUSE 3. The third challenge is the treatment of large core strokes beyond the 6 hours window. DAWN and DIFFUSE 3 had infarct volume of less than 70 milliliters. How about those patients with more than 70 milliliters? Should they be treated or not? Now, there has been some studies. The first one is a retrospective review done by Chen and his group. They stated that endovascular therapy performed within 6 hours of onset achieved higher reperfusion and recanalization rates compared to IV-TPA. Another group demonstrated that similar results in younger patients with large MRI DWI lesions. The third group were able to show that mechanical thrombectomy in patients with aspect score of 0 to 5 were able to have successful reperfusion with no increase in the rate of spontaneous ICH. However, pooled data from SELECT and TRIVO trials showed that larger ischemic volumes were associated with 90 days modified Rankin scale, higher intracranial hemorrhage rates with worse neurological status, and higher mortality rates, especially if the volume exceeds 100 milliliters. Also, there has been a reduction in the positive outcomes of 5% per hour and 27% per 10 milliliters increase of the volume and large core stroke has been shown in this pooled data. Okay. Thank you very much. By this, I reach the end of my presentation.